Sunil Kumar M. Dr. Sunil Kumar MM is the additional director in Trivandrum Institute of Palliative Sciences, which is actually a wing in Pallium, India. It is also a WHO collaborating center for training and policy on access to pain relief. Dr. Sunil Kumar has completed his diploma in palliative medicine from India and Cardiff, and he has also completed his master's in palliative medicine from Cardiff. He has more than 15 years of experience in palliative medicine. He actually heads our entire clinical services, academics, and research in Pallium, India. It's a pleasure to have you with us, sir, and over to you, sir.
Thank you, Rajeshmi. Am I audible?
Yes, sir, you are audible.
Good evening, everybody, and very happy to see all of you. But I also understand that we have about 10 or 15 people, doctors, to join for this program. I can say only 20 has been joined. So there will be many more to join for this. So this is the first type of its program, which is done by Pallium India. And till now we were conducting another course, but now we have moved to this integrated course, which covers the basic as well as advanced aspect of palliative care. So just I would share with you how it is planned. This has already been sent to you, but still I would like to clarify this. So is it visible?
Yes, sir, it is.
Okay. So today you can see the session. There are 10 live sessions, and you can see the sessions to be covered by the candidate before the live session. So today, 14th August, EPCA means it is Essentials of Palliative Care India, which we will see in a short time. Then there are some recorded videos. Then there will be presentations, which will be mostly from your side. Any of you can present a patient story. This is add to the topic which are going to be. So the presentations would be mostly from your side, and you can take a patient story which is add to the to that session. So, for example, on 24th August, before 24th August, you have to complete the pain management modules in Essentials of Palliative Care. That is module 1 to 5 in Essentials of Palliative Care, and you have to also watch the video medical ethics. Then, if a case presentation is a must, so you can actually select which would be your choice of patient story presentation according to the topic. And you will also have a patient presentation. So before 24th, you will complete the pain management module and watching medical ethics. Then on that day, we will be discussing or we will actually will ask you to ask your doubts regarding the modules from 1 to 5 and also the medical ethics. In addition, you have to present a patient story. And there will be 2 or 3 faculties who will actually answering your questions as well as moderating the case discussion. And on 7th September, pain management module 6 to 14. You have to cover pain management module 6 to 14 before 7th September. Then there are no videos to be seen and there will be a case presentation. So I hope you understood it, how to look into this time schedule. So now I will show you the where the essentials of palliative care in there and the recorded videos. I hope all of you have received the login credentials to the LMS, and yeah, I will show you. Okay. When you click on the link which was sent to you by senior, you will see a window like this, and you can see at the top on the right hand side there is login. So I am logging in, and you have to enter the username and password that was sent to you. So I am entering my username and password. So you can see this window, and then you have to click on my courses. So you will see two courses here. One is Essentials of Palliative Care India, and the other one is Integrated Course in Palliative Medicine. And so before the next class, which is on 24th August, I think. Then and before that, you have to in the Essentials of Palliative Care India. When you click, there will be this is what you will see. So you can see there will be EPCI module pre-test survey. You have to complete it, and then you have to complete EPCI module pre-test survey 2. And only if you complete those two, then you would be able to enter the introduction to palliative care. Now I am unable to click on introduction to palliative care because I have not completed this. So um, on once you complete the previous module, then only the next module will open. Okay. So I will show you another window. Give me one. So I am again logging in. Okay, you will see only the two on the left hand side, integrated course in palliative medicine and essentials of palliative care. So essentials of palliative care, I am clicking on that. Then you have to complete the EPCI module pre-test survey 1 and pre-test survey 2. Then only you will be able to click on introduction to palliative care. So I showed you that previously. So when I click on introduction to palliative care, you can see it will open, and you have to enter here. Okay. So there will be uh, at the beginning, sometimes there will be a audio of a patient who is talking, and the transcript will be on the stand. So the same transcript, you can see what the patient is telling, and then it will go on like this. Okay. And whenever you see this plus marks, you have to click on that. You have to expand that. Then only you will be able to move forward. Okay. Um, so in addition, there will be some tests, and when you submit, then only it will allow you to move forward. Otherwise, you will not be able to move forward. Okay. I am using some admin rights to show you. That's why I can move forward. So this is introduction to palliative care. In this chapter, we do not have any post test, and whenever you see blocks like this, you have to click on this, and there will be it will turn and it will show you something else. So only when you complete this, then only you will be able to uh, click to the next. Okay, continue. And you can see the course has now, we are at the end of the course. And next activity is, you can see on the right hand side here, next activity, course 1 comprehensive pain assessment. So in this, we do not, in introduction to palliative care, we do not have an assignment, but from the course 1 comprehensive pain assessment onwards, we have assignments. So click on comprehensive pain assessment. Okay, it will take you to the course 1 comprehensive pain assessment. And then, as I told you earlier, you have to enter. So it will load its contents. So actually, uh, there are many many of the texts which you have to complete before coming into the course test. I have done this, so that's why I could directly come to this course test. But I can show you uh, where it will start. Okay, so this would be the beginning. Uh, in the beginning, there will be tools and resources. There will be many articles and as well as patient stories which you can go through. And then next topic is comprehensive pain assessment. So it will be like this. So you have to, these are questions in between which will not be calculated as assignments. These are text which are, or questions which are included in the course itself. Okay. So you will not be able to go like this. As I told you, you have to go through each and every questions, then only you will be able to go forward. So there will be many subheadings in the module. So now I am into the post test. You can see lesson 7 post test. So it will be here. Okay. So this is the question 1. You can select an answer and submit. It says it is correct. Then you can go on like this. Okay, there would be mostly there would be 10 to 15% in each module. So I think we have 15 questions in the first assignment, and you have to score 80 percentage to pass the module. And if you are unable to score 80 percentage, then you can do this course again, because only if you score 80 percentage, then only the next module will open and the part 2 will open. Okay. So here. Okay, you can see my score is only 20%. Passing score is 80%. That means I have to do it again. So if you do not pass, then what you have to do is you have to exit the activity. You can see on the right hand on the top on right hand side, exit activity. Click on the exit activity. It will take us to the modules that all the modules are there. Then you have to again click on which module you have not passed. So this is the course we were doing, course 1 comprehensive pain management. So I have to click on it. Then it will be like this, and you have to you can see here there is preview and enter. Earlier we just ended, but here we have to click on start new attempt, and then you have to enter. Okay, please make sure that you click on the new attempt and then enter. Otherwise, your marks will not be recorded as even if you pass, your marks will not be recorded. Okay, so make sure that you click the new attempt. Okay, so this is how the modules are arranged, and you can see in the pain management there are 14 modules. Okay, pain management 14 modules, and then next is symptom management. In that there are 5 modules. Then communication skills, there are 6 modules, and then best practices in dementia care, there are 7 modules. And once you complete that, then there is post-test survey. So EPCA module post-test survey 1 and EPCA module post-test survey 2. If you complete this, then only you will complete this essentials of palliative care in the India module. Okay, and you can see there is the only 2 courses that you will see is essentials of palliative care India and integrated course in palliative medicine. Okay, so this is another module which you will see. So before 7 in the pain module, you have to complete 1 to 4. And you have to also watch session on medical ethics. Okay, so click on session on medical ethics. There will be recorded video. And you have to watch the video, and once the once you watch the video completely, then there will be there will be assignments on medical ethics. So you can see next activity is medical ethics. Click on that. It will take you to medical ethics. You can click on preview this. And you can see there are a few questions which will be arranged. And you select the right answer, then finish the attempt. Okay, finish the attempt. And then you submit all and finish. Once you submit your answers, you won't be able to change them again. Then you submit all and finish. Okay, then I can see, am I right or wrong? So I got it wrong. All the answers I got it wrong. So that means you have to again do this. Okay. So these are the two courses which you are going to do. So I think that just me. Are there anything else I need to talk about this?
No, sir, you have explained it clearly. So if you have any doubts, you can ask right now. We have another 8 minutes of sir, and he will be leaving.
And if you have tried to log in to LMS with your login credentials,
Yes, sir.
okay, were you able to see this courses, Essentials of Palliative Care India and the Integrated Course in Palliative
Sir,
Medicine?
I could see that video in that integrated course in palliative medicine. I was not able to find where the modules are. Now only I understood that it is in the essentials. I thought it is some other course.
These are the courses which you can see are the courses in which you are enrolled.
Okay.
So we have two courses. One is Essentials of Palliative Care India, which has actually 33 modules, and the Essentials of Palliative Care India, I think 7 videos are uploaded. Yeah, I can see Dr.
Adra, you can unmute and speak, doctor.
Yeah, hi, sir. I just wanted to ask whether we have to finish the essentials of palliative care first, then go to the integrated course, or simultaneously we can do both.
No, so I will show you once again the timetable. So, can you see this schedule?
Yes, sir.
So you can see second serial number 2, the live session on 24th August. So before 24th August, in the Essentials of Palliative Care India, you have to complete pain management module 1 to 5. And you have to, you can see under recorded videos, you can see medical ethics is named there. So that means you have to complete these two. From the recorded videos, you have to complete medical ethics. And from the Essentials of Palliative Care India, you have to complete modules 1 to 5.
Okay, sir. Thank you.
So it is not finishing one and then going to other. Both of that need to be done simultaneously, but not all the modules. The modules which are given in this schedule.
So like sir mentioned, whatever we have completed in EPCI, it's actually regarding pain management, symptom management and all. So those topics which are not included in EPC, we have included in ICPM session recordings. So those are different topics. So both combined to form the integrated basic and advanced course. So we have created a plan so that you can complete the entire two courses in a period of 2 months of time till 12th of October. Any other questions to sir?
Suppose we don't finish something in that time, then we won't be able to do it again, no?
So ideally, it should be done within the allotted time. But if you don't complete, please let us know.
Thank you, sir. And sir, what about this case presentation or discussion means in each session?
So suppose in the first session we are going to cover pain management module 1 to 5 and also medical ethics. So any of you actually can present a patient story, maybe a patient in pain or where you have faced ethical problems. So the template will be given by Rajalakshmi. She will send it to you all. So you have to actually fill in that template. We will send you a sample how to actually do a patient story or case presentation.
Okay, thank you, sir.
So you will be presenting and you will add some questions and then there will be a discussion and it will be discussion between the participants and then finally the faculty will be summarizing those discussions and what are the good practice points that we need to consider, etc. The faculty will be talking about that.
Sir, what about the case presentation that is mentioned? So when should I have to present those cases? After passing the whole this quiz, and after that we have to present the cases. Is the cases will be given to us, or we have to choose it?
So I showed you the time schedule. Please look here in the time schedule. So and you can see the sessions to be covered by the candidate before live session. Under essential for palliative care, you have to cover so many topics, and the recorded videos you have to cover. And in presentations, you need to present a patient story. Look here, on 24th August, there is a case presentation, which is to be done by one of you. So I think Rajalakshmi will get in touch with you, or senior will get in touch with you about more details. If you are working in a palliative care setting or any other setting, you can take a patient story who has pain, and you have find it very difficult to manage. So you will fill the template and you will present it, and then you will ask your colleagues and the faculty how to manage this patient. So that's the whole idea. So you can correlate with your learnings that has happened in Essentials of Palliative Care in India or in recorded videos. So you have to take your case presentation. That is not after finishing the course, it is along with the session. So each session there will be case presentation, and in the first session, it would be on pain or on medical ethics. On 7th September, it would be purely on pain. So any of you can actually volunteer to present a patient story with the template that we are going to provide. On 11th September, you can provide something on anxiety, depression, delirium, palliative care emergency. On 18th September, it is going to be some case presentation related to constipation, nausea, vomiting, and dyspnea in palliative care. I hope you understood that.
Yes, sir. Thank you, sir.
Welcome. So, shall I leave?
Yes, sir, you can. Dr. Sanghamitra has joined too, so we will move on with the next session. Thank you so much, sir, for joining us.
Okay, Sanghamitra, I am leaving. I have to attend another meeting.
Sure, sir. Thank you. I cannot take your place, but I'll definitely try to stand up to your expectations. Thank you so much.
You can definitely do that. All the best.
Thank you. Thank you, sir.
So next we will move on with the session on Introduction to Palliative Care. We have Dr. Sanghamitra Bora joining us. Dr. Sanghamitra actually leads the palliative care at Assam Cancer Care Foundation. She has completed her MSc in Palliative Medicine for Cardiff University in 2017. She volunteers for Arjuan Healthcare Foundation, an active member of IAPC National Faculty. She's also National Trainer for NHSRC under the Government of India, a very dear friend of us. We could say that we rely her on very much for our training programs. Thank you so much, ma'am, for joining us today, and it's over to you.
Thank you so much, Rajlakshmi. Not Rajlakshmi. This is Sinia.
It's Rajlakshmi only, ma'am. Both are there.
Okay, I can see only Sinia. Rajlakshmi, I can't see you. Yeah. Okay. Okay.
Here only, ma'am.
Thank you. Thank you. Thanks a lot for thinking about me. But I would like to actually tell this house that, the introduction to palliative care can never be better explained by anybody else except Dr. Rajgopal. And I'm just indebted to Pallium India and Sunil Kumar sir for thinking about me to take this session. I will surely try to do justice to give you an overview of what palliative care is all about. I'm sure you already have a background or already know about what palliative care is all about. So just trying to share my screen here. Okay. So is this screen?
Yes, ma'am. Presentation view would be good. Perfect to go, ma'am. Yes.
Okay. So I one thing that I have understood after all these years of being in palliative care, actively trying to do some bit of goodness to our patients. I would say that very proudly, because many of my colleagues and many of my junior colleagues and friends in the medical practice have actually diverted towards something else while practicing medicine. It's very important that you realize the compassion inside you. If you do not understand that you are also a compassionate person and you can deliver your work, your service to those who need you along with compassion, I think that particular cocktail generally works wonders for your patients. I would say this very proudly because I have experienced this feeling myself. I have seen sparks in people who have actually entered palliative care in a very, naive manner, and transforming themselves into a different kind of an individual. So it's very important that you you mix your emotions, your capabilities, your skills, and your learnings when delivering palliative care. I think that is very, very important. If you realize this, you are a wonderful palliative care physician, and you can do it wherever and whenever and however you want to do. That particular bug that bites you, it actually gives you, shows you the way how you conduct yourself, how you improve yourself on your skills, how you treat your patients. Treatment is a very small world, it's a very small word to say when we do palliative care. It's very conceited. But when you start giving your services, particularly to your patients, the treatment is just a smaller part of it. The rest of it all are actually the human touch, the compassion, the kind of feelings that you develop for your patients, and the most importantly, to be with the patient all the time, either virtually or physically. So I'm just revising the definition of palliative care, and this has over time changed also. But then the most important thing that you need to remember is that the quality of life of patients, as well as that of the family, is an important factor here, because all we do in palliative care is improving the quality of life of our patients and their families. At the same time, when we talk about improving the quality of life, we also talk about what kind of problems this particular patient is facing, and that definitely may be associated with the life-threatening condition, or it may not be a life-threatening condition also. Okay, it might be life-limiting illness. Okay, for example, if somebody has lost a limb, that particular person is actually going through a life-limiting condition. He is unable to walk. He's actually have to have an assisted facility for him to actually do all his daily activities. So life-threatening as well as life-limiting conditions. The most important change that has actually occurred over the years is that we right now also focus into serious health-related conditions. Okay, serious health-related disorders. So anything that pushes a person, a patient, and the family into the side effects or into the problems that are associated with serious health-related conditions are also a good candidate for giving palliative care or improving their quality of life through palliative care. And not to forget that we need to understand what kind of psychosocial and spiritual problems these patients are going through. That is the reason why in the very beginning, I talked about, the compassion that you will have to develop or will have to discover in yourself. I strongly believe that every individual, every human being has a compassionate side, for reasons unknown. We are sometimes, we need to perhaps cover up that particular side of us, need to just, wear a mask or something. But then it's very important that you discover your compassionate side for our people. And that is how you will automatically, or you will be directed towards giving them a psychosocial and a spiritual care. You do not have to go to a university to learn psychosocial care or spiritual care. That is my take. It's very, very good if you do explore these things in a systematic manner. But then as doctors, we need to discover our compassionate sides also. So this is an interesting slide that I actually found out in this Indian Journal of Surgical Oncology, where Dr. Naveen Salins and his team, where Rajgopal sir is also one of the authors, have actually delineated a very beautiful sketch of how palliative care started in India. So the green dots in this particular timeline is that of palliative care in India, and the blue dots are that of the world international developments. So as you can see, it started in the world at around 12th to 20th centuries, where a place called hospice was developed for travelers. So people used to have hospices as rest houses, and as of now we understand a hospice to be a facility where people at their end of lives are kept until they die. So that's the concept of the hospice, which developed in the 12th centuries throughout the 20th century. And the important change that occurred post the hospice development is the development of St. Christopher's Hospice in UK. I'm sure you know about Dame Cicely Saunders. She is regarded as the mother of palliative care in the world. And she modernized the hospice movement and brought about the modern palliative care movement to the world. So St. Christopher's Hospice was developed in 1967. And in 1974, a hospice developed in the US. Not very late, but around that time, in 1975, the National Cancer Control Program of India was also developed. So National Cancer Control Program, had an element of palliative care, since cancer, at that point of time, had patients of almost 95% being in the last stage, partly because of the fact that there was not much awareness about cancer, and at the same time, not much of cancer treatment facilities were developed. And that is the reason why basically our oncologists who went through the rigorous training of cancer treatment actually delivered only palliative care. Okay, so this is an important change that occurred in India. And at the same time, perhaps after 10 years, around 1984, the National Cancer Control Program was properly modified to a cancer control program and pain relief, which was started at the PHC level. So you can see that palliative care is old in India. The element of pain relief, the importance of pain relief was understood way back in 1984 itself by those formulating the Cancer Control Program of India. Unfortunately, there has been developments till now, but then we still face a lot of problems while reaching out to our patients about palliative care. Okay. Throughout this course, I'm sure, you'll come to know about the obstacles that palliative physicians generally face. But having said this, it's really not depressing, because you can see the development of Shanti Avedna Ashram in Mumbai in 86, followed by a great organization called Cancer Relief India, which was started by one of our very dear friends, Ms. Julie Byrne. Julie Byrne is a palliative care nurse. She's supposedly the first palliative care nurse, perhaps, in India. And she comes from the UK, but she delivers her care through Cancer Relief India in India. So she started Cancer Relief India in 1990. The Pain and Palliative Care Society was started in 1993 in Kerala, and followed by the coming together of all the associations or all the institutions, all the NGOs that were trying to develop palliative care throughout India, forming the Indian Association of Palliative Care. And then from the 2000s, there has been a lot of developments in India. The national program for palliative care was, started in around 2013, where there was, an amalgamation of the cancer control program as well as palliative care programs coming in together and doing a kind of a flexi program where palliative care would be delivered at the primary healthcare level. So this has gone up to 2016 of Pune Declaration, and an important development that happened was 2014, where the Narcotic Drugs and Psychotropic Substances Act was completely, changed, and the availability of morphine, oral morphine, which is which is perhaps the only drug that is available for our patients for pain relief, could be delivered to our patients through a single window, which is the drugs controller. So later on in your subsequent sessions, I'm sure you're going to learn more about these changes. But then if you see the timeline, it's more of the green dots rather than the blue ones. So palliative care in India is developing. It has taken up speed, and presently, the last conference of IPC that we had in Bangalore was a subspecialty palliative care conference, where we deliberated on renal palliative care, cardiac palliative care. We also deliberated on neurology palliative care, and then, of course, the basic generalist palliative care. So I'm sure if you are a neurologist, or you are a cardiac person, or you are a general practitioner, you will all appreciate this development, and you have a platter to choose from to practice palliative care. So, contrary to popular belief, it is not only for cancer, and it is not only pain management, and it is not only for terminal illness. So, as I said earlier, it is for all the serious health-related sufferings of patients, along with the care of families. And it helps relieving suffering and hence, improve the quality of life of both the patient and the families. I'm sorry, some construction work going on just near my house. So pardon me for this noise. So this is something that I would really want you to understand before we go deeper into what palliative care is like. So this is a picture of a person who is a 42-year-old man. He's a manual laborer. He has a cancer of the cheek and he lives with his wife and 2 children, aged 9 and 5. He comes to the OPD with a foul-smelling wound. Sorry, I'm really sorry about this. So now, when we understand what is disease for this patient and what is illness for this patient, perhaps we'll be able to understand the niche that, so we'll be able to understand the niche that divides understanding a disease and also appreciating the illness that surrounds it. So, the disease here is the oral cancer of the patient, which is the squamous cell carcinoma of the cheek, and the infected cancerous wound, as you can see, with a superadded bacterial infection. Now, the illness, if we look at the illness itself, we saw the disease. Now the illness is the disease itself, which is the squamous cell carcinoma of the cheek and the infection. The illness also includes the pain of the patient, okay? As well as perhaps the poor appetite, perhaps the losing weight that he is experiencing, the tiredness, the disfigurement of his face. 42 years is quite a small age. And, if you look at this picture, you can see that he looks more than, 60 maybe. If not 60, then more than 55 at least. So he's 10 years ahead of his own age. So he has an altered body image. The wound perhaps is smelling also, always oozing. You can see from this side that his tongue is also visible. He has been socially alienated. He is always thinking about the fact that what will happen to my family after I'm gone if I'm not treated. And the question that why has God done this to me? This whole thing that I am right now talking about, gives you the overview of the illness that is this patient is going through. Unfortunately, many of us, until recently, I would perhaps also look at the disease part, focus on curing the cancer, focus on, mending this particular wound, taking a flap from the thigh and just trying to do some kind of a plastic surgery for this patient so that he comes back to his normal. But then, I would have actually missed out on the larger scenario of the illness that this person is going through. Now, when we talk about palliative care, we need to understand the suffering of a person. And how do we do this? We need to find out what are the goals of care. Really sorry. Apologies once again. So when we understand suffering, we have to understand the goals of care, of delivering palliative care to the person. So this particular goals would be alleviating the suffering of this patient, optimizing the quality of life till the person dies, and provision of comfort in death, not unnecessarily prolonging his treatment and hence prolonging the death. So the persistent and inadequately relieved suffering is actually undermining the value of life for the sufferer. I am sure you have understood this particular statement. If we are persistent and we are inadequately relieving the suffering of a patient who is suffering from a disease like this, we are actually undermining the value of life for this particular patient, right? The alleviation of suffering is universally acknowledged as a cardinal goal of medical care. And the ability to recognize the suffering is an acquired skill. And when we say that we need to recognize the suffering, we have to develop this particular skill. We have to acquire this particular skill of recognizing the suffering of this patient. So many of you must be studying. So many of you must have learned about, the pragmatic change that has occurred from the old concept of palliative care to the newer concept of palliative care. Okay. Now, the old concept being that you have a patient who has a diagnosis of cancer or a life-threatening illness, and you start treating this patient throughout his life, or till the time you realize that this that your treatment is perhaps not going to relieve the patient of this particular, or cure the patient of the disease. Now, when the point at where you actually learn, you understand that the patient is not going to be cured, you leave the patient and you call for the palliative care physician, and the palliative care physician gets perhaps a few days or perhaps even few hours to bring about a kind of a change for this person, and then the person dies. So this particular thing of providing some bit of care process at the end of life and not including palliative care from the beginning is an old concept. Okay. But then that has been changed to, the newer concept only after realizing the amount of responsibility that healthcare professionals have for our patients, and the question that our responsibility, does it end with being able to cure or not to cure? Okay, so when we answer this particular question, we will be able to transition more towards giving a better life, quality of life to our patients. So this is the modern concept. You diagnose the patient and you start life prolonging therapies for this patient, as well as some bit of palliative care. Okay. And this palliative care could be a little bit of counseling for your patient, just going and introducing yourself to the patient, saying hello or hi, and then as the life prolonging therapies fail to cure this patient, palliative care would slowly take over the care process. And at a point where you understand, you prognosticate that the patient is at the end of life, you provide him with the end of life care. The patient dies peacefully at his own chosen place. He might choose to die at home. He might also choose to die in the hospice or the hospital. And then when he dies, you support the family through a bereavement process. You just do not abandon the family after the patient dies. You need to, push, or you need to negotiate the family, help the family in negotiating the grieving process that they are going through. Bereavement is a process where you have to understand the complexities of grief. A young child dying of cancer and the only child of a parents, you need to understand or perhaps personalize even what the parents might be going through. And when you do this, you will understand the pain, the psychological pain that they're going through, and a kind of complicated grief that they may land up. And at that particular point of time, you may have to extend your bereavements, the bereavement support to this patient. You may have to take help of a bereavement counselor who's actually an expert to do that. So everything said and done, palliative care in a modern way should be, or preferably be delivered by a interdisciplinary as well as a multidisciplinary team. I often talk about the clinical skills of medicine, what we are taught about. Definitely, we have to diagnose our patient's condition. We also have to treat, but the most important thing that we will need to do is prognosticate. If you learn how to prognosticate, you will never overtreat. Okay? If you learn how to prognosticate, you will never fail to diagnose a new condition that has come up. So it's very important in palliative care that we prognosticate the immediate things, immediate problems that are coming up. I'm not saying that we need to be fortune tellers, or we need to tell them that you'll be dying in 7th of September 2023. It's not like that. But having said this, over the past 100 years, the prognosis have been gradually giving way to treatment as the core clinical skill accompanying the diagnosis. And this is very, very unfortunate. Okay. We have failed to prognosticate And this is the reason why many of our patients are being over-treated in mushrooming growth of nursing homes. And that is the reason why over-treatment has always, have been in kind of in a hand-in-glove situation with, a lot of business things that are going on with the healthcare sector. So we will need to understand where we have to cut this, where we have to prognosticate rightly so that our patients are not overtreated. So in palliative care, as I said, prognostication is extremely important. It provides patients and their families with the information, the right kind of information, so that they can set their goals, so that they can set their priorities, so that their expectations of care are properly jotted down. Okay. Prognostication is also important to help patients develop insights into their own dying process. Okay. It might seem very kind of a finicky kind of a statement, but it's very important. If you start practicing it, you will see how patients come up with the kind of insight that they have about their own life and death, and it's not a funny thing. It's a very deep understanding of how patients actually come up with these insights. Interestingly, prognostication will also assist clinicians like us into decision making, and to compare live patients with regard to outcomes, and to provide a common language for healthcare professionals involved in the end of life care. All right. So very importantly, in this particular session, I really want you all to understand the importance of prognostication in palliative care. If you understand prognostication, if you prognosticate rightly, I think you can never go wrong in treating your patients. Okay. And this is one of the very important skills which is also going to save your skin, because once you have a backup of a scientific knowledge about scientific prognostication, nobody from your colleagues of fraternity can challenge your decisions. This is my very personal experience, and I'm sure that many other senior palliative care physicians, when you come across them, their experiences, they're going to say the same thing to you. There are certain probabilities of various outcomes of the natural history of a disease, and this is quite scientific, because if you see, there are 5 Ds, and number 1 is disease progression of recurrence, and the example is how quickly will the ascites reaccumulate. If you can understand this particular, if you can answer this question, for example, if there's a patient with malignancy in the last stage, perhaps an ovarian malignancy, let's say, and with metastasis to all the peritoneal structures, including the lymph nodes, ascites is bound to happen. And one thing that I have seen and experienced in the past is that our clinicians will not hesitate to tap the ascites, do a ascitic tapping as soon as the patient comes. And that patient may not be symptomatic. When I say symptomatic, I mean that the ascites is a part of the body that the patient is carrying. okay, and is not really disturbed because of the ascites. Only the fact that, doctor, my abdomen is swollen and, I do not feel good. These are the only two complaints. But, I've seen our doctors, our clinicians, jumping into tapping a malignant ascites. Now, at this point of time, the question of disease progression or recurrence, would actually give you an understanding of whether you should proceed with the ascitic tapping or not. How? If you ask yourself, if I tap today, how fast is this malignant ascites going to reaccumulate? And is this actually going to push the patient further into cachexia? If you answer this question, you will be able to understand prognostication for this particular patient. Similarly, the second D is about death. The question, how long have I got? This is a question that patients will ask you at their end of life. Not even the end of life, as soon as the disease is diagnosed. I have 3 patients in my family, and all 3 of them, my father, my mother, my brother, have actually asked this question, I think, n number of times till today. They are all doing fine. They're all stable with their diseases. But the question of how long have I got is a household question in my family, So if you know, if you can answer this particular question, that, okay, I see your deterioration over the last few months to be rapid, I believe you have 2 or 3 months to be. Sorry about that. Okay, so if you answer this question also, you will be able to prognosticate this person's death. Similarly, okay, so similarly, the question of disability, will I walk again? Drug toxicity, will I get addicted to morphine? Dollar cost is the cost of the treatment. Is conventional care more expensive than palliative care? So these are few questions. These are the 5 Ds of prognostication, which I will always want you to remember. And when you understand this, you will find yourself practicing proper and the right kind of palliative care. These are few pictures that of my own patients actually, and you can see, if you try to answer all the 5 Ds here, you will understand where to stop and where to start your care processes. This is a cancer of the penis. When I was undergoing my training in Palliative India, I had seen this patient with Dr. Sunil, and this picture is, it reminds me always of the difficult situations that we face along with our patients and their families. This is another patient that I had seen. This is a 19-year-old boy. And, you can see the kind of oral cancer that this patient has developed. It's a proper cauliflower growth, and we actually had a very hard time, taking care of this patient, because the acceptance to his condition was absolutely zero. Absolutely zero. Of course, it has to be. I mean, if I was a patient with a condition like this and I was just 19, I would have, I don't know how I would have reacted. So these pictures, why we preserve, I like to tell you, not for, displaying to my colleagues and my friends that I'm doing a great job. These pictures remind me of the clan I belong to, and that is the reason why, the compassionate side that I have developed over these years is being actually fueled by these pictures, these patients. They have been my teachers. I remember every step and every medication that I had prescribed to these patients. I think this is something that you all should also try to develop, and I'm sure that in your lifetime also you may have come across many examples, many patients who have had taught you many things and you have never forgotten about them. These kids, this 90-year-old Amma with a nasopharyngeal carcinoma, they are all my patients and they've taught me so many things in life. Palliative care is actually about total pain, physical, spiritual, emotional, social. And I'm sure that till now you have understood, how holistic we need to be when we actually, try to give some kind of little bit of care to our patients. Active medicine it is, definitely, because it is scientific evaluation of physical problems. It's not like, sitting with the patient and crying. You have to develop skills. You have to learn things. You have to unlearn many things also in palliative care, because we have had our MBBS and the other special degrees through our trainings, but many things might change when you actually land up with a patient who is incurable of cancer, who has a life-threatening illness. Many of your ideas may not work that you've learned. You may have to keep those aside and start learning, evaluating these patients in a new format, in a new style. So physical symptoms are just the tip of the iceberg. I have pain in the cheek because of this cancer. That is just the tip of the iceberg. When you just go down below, you will see emotional and social distress. There will be so many issues, including spiritual issues, kind of broken relationships. I've seen people who are absolutely lonely in their lives, suffering from such kind of diseases. There'll be sexuality issues. A person, a lady, young girl of 21 years, just married, landed up in, metastatic triple negative cancer, breast cancer. Can you imagine mastectomized, double breast mastectomized 21-year-olds? How how does it feel? I mean, I cannot imagine myself without a breast. Never. How would a 21-year-old react to it? Okay. So these things are important in our lives as physicians and the lives of these patients, as well as the lives of their near and dear ones. You know, the husband has to understand. He understands definitely, but you know, you'll have to find out what he has understood, what are his issues, how is he coping up with this particular situation. Is he feeling guilty about it? Is the patient guilty that, you know, my youth is absolutely worthless for my husband? Okay, so these things are extremely important. So implications of palliative care in serious diseases, cancer, you can see it's ever increasing. Current prevalence is 2.5 billion. New cancer patients registered annually. This is a report from 2012-2014 PBCR, but I do not have the latest one. I don't know whether the latest one is available or not. So from this, you know, you can actually see how magnified cancer is in India. Okay. Aging population is one thing that actually, you know, gives us everybody a threat. You know, India is an aging country. I don't know how many of you have researched about Japan, but Japan is absolutely in its 70s. All its population are in the 70s. There are very few people who are in their 20s or 30s. Okay. So at one point of time, you know, maybe it's written 2050, you know, the elderly population in India is expected to increase by around 324 million. 60% of our elderly patients at present are affected by cancer. You leave aside all other complications that are there, cardiac, renal, okay, osteoporosis, falls, you know, corneal damage, so many other things. So the elderly, if we have 60% of our elderly patients dying in cancer, you can imagine the kind of burden that physicians have in this country. And above all, you know, the question of unrelieved suffering. We have it with us. Morphine is available, but we are so scared of giving it. Why? Because morphine is actually going to give our patient a respiratory depression and our patient is going to die. So unfortunate, very, very unfortunate. These are few facts that I am just giving you. You can see the National Crime Records Bureau report of, it's 2013. This report actually gave us a overview of around more than 26,000 suicidal deaths due to various ailments, and that is actually due to suffering. Okay, hanging being the preferred choice. Patients actually hang themselves just to get relief of their suffering, and that could have been actually properly relieved by you know, proper use of agents like morphine. Well, we actually came through a long time. I mean, you know, we struggled through the NDPS Act also. And interestingly, we brought about the drug reform in India, the drug policy of India, and thankfully the NDPS Act has now been properly so presently we do have good news also. We have a national program for palliative care, as I've already talked about, created in 2012, and it's part of the mission flexi pool of the national health policy. So when if you go back to your own states, you talk about mission flexi pool to your NHM guys, and I'm sure they do have a kind of a pool for their national program for palliative care. NDPS Act has been amended. The new act is enforced from 2014, and now we have easy access to oral morphine. Much of the training and education is also happening in India. Specialist palliative care is being taught as MD palliative medicine now. It started in Tata Memorial Hospital in Mumbai, and then All India Institute and many other things, other institutes have followed. And interestingly, if you are interested for a DNB, that is also now available. That's a good news for young people who really want to pursue palliative medicine. Pallium India has been a pioneer in, providing certificate and fellowship courses. I am really proud that I also did my certificate course in Pallium India, and other, many other volunteer courses. And I think IAPC has also come up with a lot of courses, orientation courses for physiotherapists, for pharmacists, and other things like that. But if you really want to pursue palliative nursing or palliative medicine, and you should go through a proper training curriculum. So the big question is, how do we want to die? Because we are in palliative care. Let us not forget that we are dealing with death. And if we run away from this situation, try to shoulder our responsibility on the ICU nurse and the ICU doctor, then perhaps, we are not actually doing what we need to do. So the big question is, how do we want to die? I would like to die with my people around, my son, my family around, at my home. And, I would also consider myself, as a small thing, but with a capability to bring about a change in the kind of situation that we are in as of now. So this is a very lovely proverb that I want to show whenever I'm talking. So it's an African proverb that says, you think you're too small to make a difference, then you have obviously never slept in the same room as a mosquito. So, we all need to find out that particular bug inside ourselves and create that particular sense of bringing about the change in ourselves and bringing about the change in the care, the goals of care that we design for our patients. So thank you so much for this patient hearing. I am absolutely apologetic for the background music that had happened in the middle of the presentation. I hope it has not affected much on the message that I wanted to deliver today. So thank you so much, Rajlakshmi. Any questions that anybody would like to ask?
Thank you so much, ma'am. Definitely that there was interruptions, but it have never affected your class at all. So, ma'am, I know you have to leave right now. So, before that, there was a question in the chat. Dr. Priya was asking, what is the difference between hospice care and palliative care? Your thoughts in it, ma'am?
Yeah. So, as I might have actually mentioned, hospices actually started early in the 12th century, in the 20th century. Um, uh, but palliative care as a whole, can be delivered in a patient's house. It can be delivered in the outpatient department where you practice. It can be delivered in the hospice itself. It can be delivered in the ICU. It can be delivered in the hospital. So essentially, you can deliver palliative care anywhere. Okay. So hospice care is a part of palliative care. Essentially, palliative care is a larger umbrella, and hospice care is a part of it. So palliative care involves symptom management, psychosocial issues, it involves spiritual care, it also involves emotional care. So you can keep on adding to it, your physiotherapy, your compassionate care, supportive care, everything comes under the larger umbrella of palliative care, where hospice care is a part of it. Hospice care is exclusively delivered in a setup where we know that our patients are going to die, and we are not going to give them any kind of resuscitation. We are not going to refer them for any kind of curative therapy also. So this is perhaps, I hope this concept is clear now.
Yes, ma'am, it does. Do you mind if we have two more questions?
Okay, it's okay. No problem.
Okay, so Dr. Anju was asking, who all can write oral morphine for patients legally in India?
So, you see, Dr. Anju, you have to have at least a 15 days of contact training in palliative medicine, in pain and palliative medicine, to be licensed to write morphine. Okay. So many things are happening actually in other setups, but legally, this is the right way. Whoever writes morphine or any other opioids, strong opioids for that matter, they have to have a minimum 15 days contact um, in palliative care.
Thank you, Dr. Sanghamitra. Just to add on, during the ICPM course and session recordings, there is a detailed session on opioid availability. You can watch that video, and on 21st September, we are actually having a discussion on this topic, opioid availability and organizing palliative care services. So if you still have doubts regarding opioid availability, you can ask us there. Thank you, ma'am. So the next question is, when was the modern definition of palliative care introduced?
Okay. So this is given by WHO actually, and it's been a long time. I really can't remember, but then the modern definition has been coined by the WHO. Okay. Um, very recently, it has actually revised the definition to include serious health related suffering also. Does that answer your question, Dr. Riddhi?
I guess it does.
Yeah, okay. Thank you. Okay.
We are joined by Dr. Sridevi Warrior. She actually
Hi,
heads the entire education and training for us. Welcome, ma'am. So if you have any persistent question, you can ask us right now. I take it as a no. Dr. Sridevi, do you want to add something?
No, I
Anything?
just wanted to thank everyone for joining us for this program. Thank you, Sanghamitra, for the wonderful session. I've been listening to it. I was unable to switch on my video till now. So I wanted to tell the participants, if you feel stuck anywhere during the course, there is a WhatsApp group, so you can always reach out to us in terms of if you're unable to access to the materials or recordings or anything. Our team will be there to help you with that. Any other questions regarding the whole course? We are happy to take up. Otherwise, we can find out.
Yes, Dr. Chandrika, you will be getting the recording of the session.
Yeah, plus there are many recordings as they have suggested. So for sessions, kindly go through those once you are going through the course.
Yes, the WhatsApp group we created, we have disabled everyone to chat in it. It's just because it's being the first session, we don't want messages from our side to get unnoticed. So from tomorrow onwards, we will open the WhatsApp group so everybody can comment in that too.
All of us are there in that group, the coordinators and the facilitators, so you can reach out to us through the WhatsApp group.
Shri, I'm sorry, Rajlakshmi, can I just log off? I need to.
Sure.
Yes, ma'am.
Please.
Thank you so much.
Thank
Thank
you
you
so
for
much.
going.
Thank you so much. Yeah. Bye. Bye, everyone.
Bye.
I think if there is nothing else, then we can wind up this session.
Yes. So like all participants can start doing the LMS software, EPCI and ICPM program. If you have any doubts, make sure you reach to us. We really want you to complete the entire program in 2 months of time. So don't waste any of the time. You have any confusions, any doubts, please reach to us. So we are meeting next on 24th August. In that day, we'll be having discussion from the pay module of 1 to 5 from EPCI and medical ethics sessions recording from ICPM session recording course. We have shared the entire details, the entire PDF files to you. So any doubts, please reach to us without wasting your time. That's what. Dr. Sridevi?
Yeah, that's all. And if you have any patient stories to discuss during those sessions, please, that's highly encouraged. If you're stuck with any pain management, once you go through these modules, please bring up those scenarios also so that we can all learn from each other. That's all. Rajlakshmi, they have asked about the timing on 24th August.
Every sessions will be from 6 to 7:30, this timing only. Every 9 sessions from now will be from 6 to 7:30 only. The actual dates are sent to you in the PDF file. You can look into it. And also the template for case presentation, we can send you a sample one, but it need not be in that form itself. Whatever strikes you, whatever unanswered question for any patient story you see, you can send us. Okay. So thank you all for